So today we're going to talk about our article around diabetic kidney disease and mechanisms for kidney protection in patients with diabetes. And in the article we cover a variety of different areas, including more traditional markers of kidney protection, such as improvements in metabolic parameters. And we also do a lot of focus on the non-metabolic factors, such as blood pressure and those that are related to natriuresis and sodium-related pathways and mechanisms.
I mean, it's really exciting to talk about SGLT2 inhibitors because of the exciting outcomes that are being generated. But one of the reasons that we wrote our article was to focus on things like what are the real mechanisms for that initial dip in that GFR, and what are the mechanisms that might see that GFR sustained through the course of a lot of these trials, rather than drift downwards and downwards and downwards, as you see in the placebo group.
Absolutely, and some of those same mechanisms that are related to changes in renal function and preservation of kidney function, which we discuss several pathways, including sodium-related pathways and changes in tubuloglomerular feedback, so the impact on the afferent or inflow arteriole in the kidney. Those same sodium-related pathways are probably also responsible for the reductions in albuminuria that are seen in both the pre-cardiovascular trial era, so in glycemic control studies, and that have also been shown in EMPA-REG outcome and in the CANVAS program. So those reductions in glomerular hypertension are probably in large part mediated by natriuresis and hemodynamic effects.
One of the exciting things about understanding the mechanisms by which SGLT2 inhibitors work, particularly in the kidney, is understanding how they might synergize with new strategies or other strategies that are also out there, how they might synergize with DP4s, with GLP-1s and other kinds of things to get the most for renal protection in our patients.
Yeah, we just had a really nice session during this EASD about combining therapies with DPP4 inhibitors, and talked about a lot of the similar or analogous mechanisms that happen with SGLT2 inhibitors versus DPP4 inhibitors and GLP-1s, and talked about the natriuresis and the anti-inflammatory effects that may mediate some of the protective hypotheses around the incretin therapies, but that also distinguish them from the SGLT2s, which have these impressive, interesting effects on both albuminuria and blood pressure and GFR, and of course on hard renal endpoints that have been shown in the secondary analyses from EMPA-REG outcome and CANVAS. And what's also so interesting about speaking of sodium, is the blood pressure lowering. And that's another focus for the article. And that's important because, of course, we strive to improve the blood pressure control in our patients, which tends to be mediated by glucose-related effects and also by volume expansion and sodium, which the SGLT2 inhibitors may impact on. But there's also this whole other fascinating literature around the non-direct sodium effects of the SGLT2s that may lower blood pressure, such as arterial stiffness or changes in endothelial function, and other systemic hemodynamic pathways that lower blood pressure, but that could also potentially mediate some of the cardiovascular effects around heart failure risk, which of course it wasn't our focus, but still interesting to link the heart and the kidney potentially through these sodium-related pathways and also through hemodynamics.
And that's the exciting things that comes out of these clinical trials. You see observations that say, oh look, there's a lower blood pressure, and then of course you go to the point saying, how does that blood pressure go down? How might we get the most out of it? Which patients have the best reductions in blood pressure? So for example, with SGLT2 inhibitors, you see people who have got narrow pulse pressures benefiting the least, and those with wide pulse pressures, those who are mostly volume dependent, benefiting the most. And so now we can start seeing how volume is the driver of those things, and we describe this in the article.
Yeah.
One of the other exciting things about SGLT2 inhibitors is not just they have effects on cardiovascular or renal outcomes, but they affect the kind of metabolic parameters that most of our patients really care about, which is their glucose control, and in particular the weight loss with the SGLT2 inhibitors, which has really been the biggest boon for this class of agent, even before the cardiovascular outcome trials. And what was really not understood was exactly how they lost weight. Your patients would take them, suddenly their pants would be thinner, suddenly it would be their dress size would be smaller. They didn't know. And so now we've been able to put all of the data together about the mechanisms by which that weight loss occurs and why it might not be ongoing, despite the ongoing glycosuria, why it sort of really plateaus out after a period of time.
Absolutely, and along those same lines as dissecting risk and figuring out who will do the best over time. Although we're still waiting for the full results of Credence to be released and to be made available. It seems like, based on data from EMPA-REG outcome and Canvas, that albuminuria is another surrogate marker that we can use in dissecting out who has the best effect on renal function preservation, since the patients who have macroalbuminuria at baseline seem to be the ones who have the biggest effect on preserving kidney function in SGLT2 inhibitor treated patients versus the placebo treated patients. What's also so important about the sodium non-glucose pathways that have been elucidated and thought about from the existing data in the field is where this field is going, which is into non-diabetic CKD2. So that, for example, in the DAPA-CKD trial and in EMPA-Kidney, there is going to be a significant proportion of patients in those trials who don't even have diabetic kidney disease as the cause of their CKD. It's going to be all comers. So what's been so fascinating about how this field has evolved has been going from glucose to sodium, and from sodium to cardiovascular, but also from sodium to outside of diabetes. Using a drug that was developed and targeted for glucose is now going completely outside the fence to look at effects in patients who have non-diabetic causes of their kidney disease.
And some of that is through understanding what happens in patients with chronic kidney disease. So what's really fascinating is that when you use an SGLT2 inhibitor in someone who can't clear creatinine, even if you use put a little bit of glucose into the urine, you don't lower the A1C very much, and yet you have the cardiac and the renal benefits. That suggests that it's not working by lowering glucose, but actually through these other mechanisms altogether. Equally, if you have a patient who has got enormously high GFRs of 190, big, early diabetic, you give them an SGLT2 inhibitor, so they have this massive glucose lowering. So we now recognize that it's not just the ambient glucose, but it's the ambient glucose multiplied by the GFR that sets your level of glycosuria, and that controls your achieved glucose reduction. It's nothing to do with your renal benefit, it's nothing to do with your cardiac benefit, but it does determine your overall A1C lowering.
Absolutely, and people who have impaired kidney function, they not only have, or differences in kidney function, impaired versus high, there is definitely this loss of glucosuria as GFR declines. What's also so interesting is that there doesn't appear to be the same loss of or attenuation of the effect of sodium in natriuresis as kidney function declines, so that in patients with a GFR of 30 or a GFR of 90, there's still this typical characteristic GFR dip that's seen when the drug started. That's because of this afferent constriction and a reduction in glomerular hypertension. We still see the effects on reducing albuminuria in patients with impaired or preserved kidney function, and still see the effects on blood pressure lowering, which is probably also mainly sodium mediated. So the sodium effects are preserved regardless of baseline GFR, and that's also been seen when translating the GFR into clinical trials and seeing whether there are patients who benefit more or less from these agents in EMPA-REG outcome. In the Canvas program, patients benefited across the range of GFR that was studied. So it doesn't matter if you have impaired kidney function, have very little glucosuria, and hence very little weight loss and A1C lowering. Those patients with impaired kidney function still derive those cardiovascular benefits and still seem to have those renal benefits too. So it's a nice illustration of translating physiology into outcome trials.
Yeah. And understanding that physiology really provides the logical basis for the next step that you spoke of earlier, the next step of moving towards patients without diabetes, maybe with impaired glucose tolerance, maybe with uremia, but with non-diabetic kidney disease, because the mechanism is the means by which you can say, well, if it works here, it's not lowering glucose and it protects the kidney, then perhaps it'll work elsewhere. And that's where the new trials are so important to take up the mantle of where we got to now and move on to the future.